Good. So this is the second talk, which has been arranged for the IVF network, and I thank them very much for the invitation. I'm Jonathan Ramsay. I'm a urologist who specializes in the diagnosis and treatment of male infertility and subfertility. And we talked earlier about semen analysis, but this talk is about where surgery may be helpful to find sperm that are not in the ejaculate. So this is a case which is broadly termed azoospermia. That means that there are no sperm in the ejaculate, and the man has had 2 or 3 or 4 semen analyses, careful semen analyses, not done by a home testing kit, but done in a laboratory with the ability to centrifuge or spin the ejaculate fluid to make absolutely sure that there are no sperm. So we are talking about azoospermia. Now, there are 2 types of azoospermia. There is azoospermia that may be due to obstruction, a blockage somewhere between the testicle and the epididymis, and I'll show you a model in a moment, a blockage that occurs somewhere between the source, the production source, the testicle, which is regarded as a factory, a blockage somewhere between that point and where the sperm enters the urethra in the penis. So in a case of obstructive azoospermia, the testicles are working. The factories are churning out or trying to churn out usually a normal amount of sperm, but they just can't get out. Now, quite clearly, in that context, then if we look in the testicles, we will find sperm. So in obstructive azoospermia, a surgical sperm retrieval is likely to work. So we're first talking about obstructive azoospermia, and the simplest analogy, the way to think about this, is that the man has a vasectomy. Now, often, of course, when a couple have been trying, there won't be any question of vasectomy, otherwise we'd know why there was no pregnancy. But having had a vasectomy, there will be obstructive azoospermia. Sperm is continuously made, but it just can't get out. So let me show you a simple model of where those obstructions may exist. Thank you very much. So here is the model, and the model is showing a hemipelvis, that is the pelvis cut in half. So here is the sacrum, here is the lower spine, here is the abdomen, and we are looking into the male pelvis, which has been cut in half long ways. That's called a sagittal section. So the cut is straight down there. So it's at the level of the belly button here, and you can see half the spinal cord there. And now if we look down here, here is the penis, and here you can see the testicle, and here you can see the epididymis, that is the little bit on top of the testicle where the sperm emerges, and then it comes all the way up here in the vas tube. Follow my finger. So this is the scrotal sac here, and the vas is traveling up here, and then it's diving backwards into the body, very close to the back passage here, the rectum. And then it's coming round in this direction, and in fact wiggles its way around the base of the bladder, and then actually joins the penis where you can't see it in there. So if we just detach that bit, then we can see where, now we're looking into half the penis, and we're looking into the urethra here. There's the testicle, and of course all that wiggly vas tube has come around like that, but the urine flows from the bladder here down the urethra And actually, the sperm, the vas tube, enters the vesicles, the storage tank here, and the ejaculate enters the urethra just there. And so the obstruction can be anywhere from the testicle, all the way up that vas that we saw, and all the way round to the back of the prostate. And so obstructive azoospermia means that inevitably there will be sperm in here, and usually sperm in the epididymis. But the obstruction in the vas can be anywhere in its length. So, of course, a vasectomy cuts the vas down here. And if a man's had a vasectomy, it's possible to rejoin the vas, called a vasovasostomy, or possibly even plug the vas here into the bulging epididymis, which is called an epididymovasostomy. But there might be obstruction round here due to inflammation or infections. And sometimes a man is born without the vas tube at all. The testicle works, the epididymis is full of sperm, but there just isn't a vas. And that is a congenital abnormality. It's not usually associated with any illness, but it is interesting that in boys and young men who actually have cystic fibrosis, then it is quite common for them to have some abnormality of the vas, either a complete absence or an absence of a bit of it or an absence right over there. So this is the anatomy of obstruction. It's called obstructive azoospermia. We must be sure that that's what it is. We need to do a physical examination. We need to do an ultrasound scan. We often need to do an MRI scan to look at the prostate and to see whether all the tubing is joined up. And we need to measure the hormones. And of course, we need to make sure that the genetics are also normal. But if we have diagnosed obstruction, then in a very high percentage of patients, 90%, maybe a little bit higher, we should find useful sperm. So this is a straightforward anatomical proposition. All the hormones are working, the genetics are in place, but there just aren't any sperm in the ejaculate. And then one undertakes a surgical sperm retrieval, either from the epididymis or from the testicle, or both. And the term for that is MESA, that's capital M-E-S-A, that's microepididymal sperm aspiration, or TESA, which is a testicular sperm aspiration. You might choose to do a micro-TESI because it's really rather less damaging, but if it's obstructive azoospermia, the precise technique is not so important because we know as surgeons, as microsurgeons, that we, in all probability, are going to find sperm. And then the only other question is whether we should use that sperm freshly to inject the eggs, or, as is much more common and in obstructive azoospermia is perfectly reasonable, to take the sperm, prepare it carefully in the laboratory, and then freeze it carefully, and then it can be thawed for subsequent use. But of course, that does mean, the subsequent use, that we are committed to a cycle of IVF using the ICSI technique, which is about injecting single moving sperm into good quality eggs. Sometimes one can combine the sperm retrieval with a reconstruction, because if it's the case, could I just have a look at the model again, and we'll show you the model. If it's the case that the obstruction is down here in the epididymis, right down there, if that's where the obstruction is, and the sperm is coming out of the testicle, it's going into the top part of the epididymis, but it's not getting out beyond there, then one can take the vas tube and plug it into here. And that is called an epididymo, there's the epididymis, vasostomy. Ostomy means a hole. So you're plugging the the vas into the top of the epididymis. But you need a microscope to do that, and it's quite it's a very satisfactory operation when it works, but it's technically difficult because you're joining a very tiny tube to a much bigger one, and that requires some time and application and good magnification. So that's the obstructive azoospermia and where surgery can help. The more difficult proposition is non-obstructive azoospermia. So this is the man in whom we have proven no sperm in the ejaculate. Just a few of these men have a very few, but unreliably so. And in these men, the problem is that they're not making sufficient sperm to get out of the testicle, or in about 50% of cases, they're not making any sperm at all. Now, sometimes in maybe 10-15% of cases, we can diagnose a genetic cause for this. It may be that the chromosomes are abnormally balanced or arranged, or it may be that the Y chromosome that determines maleness is missing a little bit of instruction. A piece on the Y chromosome isn't there, and therefore the testicle has not developed properly. But in fact, in my opinion, and more importantly, in the opinion of a lot of scientists much cleverer than I, there are probably many other genetic candidates, genetic malformations responsible for this phenomenon of non-obstructive azoospermia. And it may also be that this is where the environment has had something to play, a part to play, because of chemicals in the environment during development which have lessened the ability of the little tiny fetus and the infant to produce enough testosterone for the testicles to develop all their proper functions. So this non-obstructive azoospermia is when there is factory failure. And the factory may be failing for genetic reasons, detected or undetected, but it can be failing in 3 different ways. It may be that nowhere in the testicle is there any sperm production. That is sometimes called germ cell aplasia, meaning that the germ cells, those cells that germinate and produce sperm, are not there. Aplasia, not made, just absent. So that's one serious cause, and if that is the cause, and if that is throughout the testicle, then our sperm retrieval or our attempts to retrieve sperm will fail. And these men will never have had any sperm in their ejaculate. The second possibility is that the production lines are working, but they're only working in part. So they're not working to the point at which they're able to produce wholly mature, good quality swimming sperm. And this condition is called maturation arrest, an arrest of the maturation process, of the development process. So if you use a fatuous analogy of a car production line, you look down from the top and you can see a whole load of cars and it looks fine, but when you look sideways on, they haven't got any wheels. So the sperm can't swim. They haven't got tails. They are therefore perhaps spermatids, or possibly they've not even got to spermatid stage. They're the stage before that, which is called a spermatocyte. So the second cause of non-obstructive azoospermia is maturation arrest. The first cause is Sertoli cell only syndrome or germ cell aplasia. The second cause is maturation arrest. Now, the third thing that might exist, which we hope exists, is certainly an underproduction of sperm, a hypospermatogenesis, but areas where there just are a few sperm. And that's when the surgical sperm retrieval is successful. But what we have discovered is that all three of those conditions, so very scant sperm production, maturation arrest, and germ cell aplasia or Sertoli cell only syndrome, those conditions can coexist. So it's not really good enough just to take a few biopsies and say, oh, well, it's Sertoli cell only syndrome, or, oh, well, it's maturation arrest. Because somewhere amongst those abnormal areas of abnormality, there just might be a few little areas of sperm production. And it's because it may be clouded, hidden, confused, that in true non-obstructive azoospermia, the right thing to do is not just a biopsy, not even multiple biopsies, but generally speaking, a microtesy or a microtesticular dissection. Now, I have a couple of photographs that, in fact, I keep on my desk. I keep them facing me because I don't want to upset new patients and their partners by them looking at the inside of somebody else's testicle before we've even begun. But these two photos do show what we do in a microtesy. And there are two of them. The first of these photos shows the capsule of the testicle. It's called a tunica, like a tunic. And this is the white area here. So here's the testicle, and it's going up that way. So this is the bottom of the testicle here, and this is going all the way up to the top of the testicle. And this picture is magnified, I suppose, about 6 or 7 times. And what it is showing is that as the wall, this tunica or capsule of the testicle, is incised, so the tubules that make the sperm begin to bulge outwards. So it's a little bit like opening a book, and as you open the book, so you can see the lines of print on each side. Now, in order to try to find out which of those tubules may be making sperm, we have to turn the magnification up, and we have to look to see where there are some tubules, some seminiferous tubules, which make the sperm, whether there are some of those tubules that are bigger than others. And so the next picture shows this area down at the bottom. So we've already looked up here, and we can't find any of those bulging tubules, those big normal looking tubules. So we've come to focus on a small area down at the bottom of the testicle. Now, to get an appreciation of this picture is magnified maybe 16 times, 15 times, maybe a little bit higher. And to put this in context, we are now looking at that little area in the testicle having actually opened the tunica. And so that you can get an idea of scale, these forceps, and you can see actually that the two parts of the forceps, one is seemingly much bigger than the other. This is because these are tiny forceps. They're actually called watchmaker's forceps. And those points are not much bigger than a thick sewing pin. Certainly not much bigger than the end of a tiny nail that you might use to hold up something very light and flimsy. So these tips are very, very small. And you can see if you look around here that there's some straggly little bits of tube that don't look very substantial, that look really as if they were hairs. And there's some other ones over here that look a little bit collapsed, But where the tips of the forceps are, you can see that there are some bulging tubules, and this is a very good example of a tiny area within a testicle, because of course, if we expand this to the whole testicle, then the whole testicle will come out to where my hands are. So this is a very, very small localized area. So when one sees this with, as I've said, 15, 16, or maybe even 20 times magnification at operation, then one looks at that area and one thinks there's probably sperm there. So we dissect that little tubule and we give it to an embryologist, because you've got to have an embryologist with you, and the embryologist will then, with a little micro rolling pin, will roll those sperm out and will say, yes, they're sperm. They may be just moving, but if they're treated carefully, they may begin to move. And so you've got to have a real-time assessment. It's no good just firstly taking biopsies, that is big chunks of testicle, and hoping for the best. It's no good just taking bits of testicle and sending them off for diagnosis. What you need to do is to carefully look for the tubule that is most likely to have sperm in it, and then get real-time information from an embryologist who is actually experienced in looking at very small numbers of sperm, because there will be very small numbers of sperm in non-obstructive azoospermia in 50% of cases, but they will be small numbers, and it may take some time to ascertain whether they're there or not. So we don't want somebody in a hurry who's used to looking at millions of sperm or even thousands of sperm. We want somebody who's used to looking for 5 or 6 sperm, for 7 or 8 sperm, because these are precious. So this is going to take some time, and it may have to be done in both testicles. So the micro-TZ operation, which is what we're talking about here, that is a micro-TZ. The micro-TZ operation requires time, it requires a general anesthetic, it requires on-site laboratory staff, and it probably requires 2 or 3 weeks of recovery and taking things easily. And I certainly wouldn't recommend any of my patients to go to the gym maybe for 2 or 3 months afterwards, because it does take some time to recover. So we talked about the relative ease of finding sperm in obstructive azoospermia and the relative difficulty of finding sperm in true non-obstructive azoospermia, and the fact that if we're going to do a microtesticular sperm dissection, as I've shown you, one needs a lot of support, one needs a general anesthetic, one needs experienced embryologists, and one needs lots of time. And because we're dissecting the testicle, and we might dissect both, we need to be warned that in a man whose testosterone might be a little bit low anyway, then there may be a need in the future to replace the testosterone. This is a very big undertaking, and we have to know and understand that it's only going to succeed in 50% or slightly fewer cases. So we've got to be prepared for the worst. And it's very difficult for us human beings to really understand what a 50% chance means. Now, of course, just talking about it here, then we can rationalize it perfectly, and we can say, well, a 50% chance of success means obviously a 50% chance of failure. But being human beings, all of us being desperate for a positive outcome, then we tend to concentrate on the 50% success. And our psychology, which is always tends to optimism, particularly when it involves another person, our partner, and a baby, says, oh, well, if it's 50-50, it's probably a bit better than that. But actually, of course, 50-50 is 50-50. And therefore, we need to prepare ourselves for the possibility on the day that there aren't any sperm. And that's quite a big psychological blow, which I think is often underestimated, because all of us go into this with understandable, but I would say over-optimistic hopefulness. We understand why, but when you're really hopeful and it's something you really, really want, and then it fails, it's always devastating. So we have to manage that fallout, and I think often we're not very good at doing that. So, is there any way around this? Well, occasionally I will do a testicular mapping procedure before we get to microtesia. So this is a procedure to try and diagnose whether there are any areas of sperm, so that if there are, we know where to look. But it's only in selected cases, because it puts another step into what is already a long and arduous journey. And if patients are private patients and paying for this, or have been forced into a place where they feel they have to pay for it because sadly the services in their area haven't been adequate to deliver, then of course doing another diagnostic procedure will add expense, therefore more emotional pressure and time. So the testicular mapping procedure as a prelude to microtesia, I think, needs to be used sparingly, but it is a possibility. So we talked about the obstructive, pretty straightforward, but be sure of the diagnosis. The non-obstructive, once again, be sure of that diagnosis and full investigations, which may culminate in quite a big procedure, a technically difficult procedure with only a 50% success rate, with all that failure might entail. And I really hope that if you are in that situation or have been in that situation, that the people who've looked after you have been as good at managing failure as they are at managing success, because surgeons like to succeed, and there are not many operations we do that are only 50-50 successful. So this is an unusual place to find yourselves if you're in that place, and you have my sympathy if that is you, and I hope not only that things will go well, but if they haven't gone well, that awful situation has been sympathetically managed. Thank you very much.